The patients are identified when they come into the hospital as being really belonging to the Dartmouth-Hitchcock Clinic on a particular team. And so the VNA gets involved from the beginning and not just after discharge. And so they're alerted to what happens in the hospital on a more intimate basis. They have more interaction with the discharge and what are the recommendations at discharge on a first-hand basis rather than just reading the discharge summary. And they speak with the social workers and the care coordinators at the hospital before discharge.
Patients have a hard time understanding medical jargon, as you or I sometimes do. So really trying to understand what the patient's learning needs are and tailoring our education based on what their learning needs are very important. Making sure they understand their medication instructions, making sure they understand how to take care of themselves, what kind of dietary issues that they may have, and talking to them in a way that makes sense to them and is real to them. Because if they don't understand, they're not going to follow through and they'll be back in the hospital.
Aside from just hospital discharges, it's also targeting patients who have coronary artery disease, congestive heart failure, chronic obstructive pulmonary disease, the frail and vulnerable. I think those are the major targets.
Since we started the project, we have identified the patient's perception of what medicines they are supposed to be on versus what they are really taking, what the physicians are prescribing. There is a great disconnect between what's happening at home front versus what's happening in the office.
I go through every pill they have, everything they take, how they take, and I ask them to explain to me. They can say, let's say laces. I take laces once a day. Well, how much they take? Oh, I have 40 milligrams. It's like, well, can you show me? And they have old bottle of 20 milligrams of Lasix that they don't even know. They didn't see the dose, but it says take one tablet every morning. So they're gonna take one tablet. It's a crucial medicine for their heart failure. It's crucial to keep that fluid out. And it's the biggest mistake I see out there.
I'm the point person for the primary care department at Dartmouth-Hitchcock. I work very closely with SENADA and the visiting nurses, although I'm not employed by them. I'm employed at Dartmouth. It's been amazing, the response that we've gotten since SENADA has really embraced this. I can't say enough about that nurse and what she does for these patients and for our patients and our population as well, all the way down to the provider level.
The same visiting nurse going and seeing the patient gives the continuity of care. So pretty much she knows everything about that patient's social and the emotional and physical well-being. So that helps a great deal in preventing the admissions.
One of our patients just recently came in with a sore and was diagnosed that day with severe diabetes. She had diabetes that was so out of control, but she had no money. She has nothing coming in, no job, no insurance, and she needed insulin, she needed glucometers, she needed the testing strips and all the supplies that go with that. And through this program, the Umbrella, we were able to provide her with a good start, teaching, resources, medication. To this day, she tells us that she loves us. I love you. I can't even believe that you're like this. So they're very, very grateful.
We all have our charts. We all have plan of care. It's one patient. So what this program helps is to start from middle. It starts from patient-centered care and spread out, out. Include everybody else from the patient's perspective. What patient can do, what best suits them in their home, because that's where it's supposed to be happening, in their home. So getting all of us together to serve that one patient. So just basically, it's a patient-centered care. That's what technology allowed us to do, and that integration and sharing the charts.
It's really worth when you can take care of the patients at home with the available resources or we can bring them in the office and give them the appropriate medications to treat their condition. That prevents the hospital admission. So once we prevent the hospital admissions, I think we had saved a whole lot of cost, expense.
We've seen a reduction in our rehospitalization rates of patients on service now that are part of the project. We've also seen an improvement in patients' ability to take medications from when we admit them to when we discharge them, which is a very significant process improvement for our agency.